ma'am. Bismillahirrahmanirrahim. My name is Dr. Asad Mahmood Khan. I'm currently working as the PGI in the I Unit 2 of the LGH. The topic which I'm going to present is cryotherapy. Now, the other name for the cryotherapy are cryosurgery, cryoablation, cryocautery, and the cryogenic surgery. In this technique that uses an extreme cold produced by an instrument to freeze and destroy the abnormal tissue. The term cryotherapy comes from the Greek word cryo meaning cold and the therapy meaning cure. It was initially introduced in 1899 by the White. He was the first person to use the cryogen in the form of liquid gas from the medical care. In 1933, cryotherapy of the eye was first reported by the Betty to steal a retinal tear by a probe, pre-cooled in a mixture of carbon dioxide and the acetone. In 1961, Cryo Probe first used for intracapsular cataract extraction. Advances were made in the treatment of the retinal tears and the detachment with the cryotherapy by Shepens and the Linkoff. Cryotherapy also used for the treatment of variety of benign and the malignant eye tumors. Now, what are the cellular effects? The basic mechanism behind the cryotherapy is ischemic necrosis. What happens is that there is vascular stresses and the destruction of the small caliber blood vessels. Ice crystals forms inside the cell, which lead to a cell wall destruction. There is denaturing of the protein. Osmotic stress develop because of this, and tissue necrosis happens. What happens is basically cell apoptosis after freezing injury by build-up of the toxic concentration of solutes inside the cell. Now, what is the thaw phase? Thaw phase means unfreezing of the tissue. For adequate cellular destruction, the thaw phase of the cryotherapy is just as crucial as the freezing phase. Slow thaw phase means there is adequate freezing of the tissue, so there is more vascular stenosis and the tissue will be destroyed adequately. The effect is enhanced by the repeated freeze-thaw cycle, usually performed 2 to 3 times, known as double freeze-thaw technique. Salient features of the cryo application in the cellular and the clinical ophthalmology. The ability of the cryogen to freeze is dependent on its ability to remove the heat, which is determined by its boiling point. The ice ball which is formed by the cryo probe becomes warmer as the distance from the cryo probe is increased. A rapid freeze and a slow thaw phase produce most cell death. Pathologic hallmark of the cryotherapy is ischemic necrosis. Large blood vessels are more resistant to the cryo injury as compared to the small vessels. Now, what are the various cryogens we use in the ophthalmology? Freon, its boiling point is minus 29.8 Celsius to minus 40.8 Celsius. Nitric oxide, its boiling point is minus 88.5. Solid carbon dioxide, its melting point is minus 79 Celsius. Liquid nitrogen, its boiling point is very low, it's about minus 195.6 Celsius. By far, it has the lowest and it is most effective in the cellular destruction. What are the different equipments? Cryo console, appropriately sized probe, cryo probe for the procedure, source of electricity to run the cryo console. The cryo probe connects to the cryo console with the insulated tubing that is part of the probe itself, tank in the gas. It is attached through the valves and tubing to the cryo console. In all retinal cases, an indirect ophthalmoscope and the condensing lens is also required. What is the cryo probe? Cryo probe is basically a closed system where the cryogen is circulated within a metal probe and the cold probe is applied to the tissue. Specifically, the probe is supplied with a cryogen from a pressurized source. For example, if the cryogen is liquid nitrogen, it converts to gaseous nitrogen when released and allows to pass within the probe, cooling the probe to extremely low temperature. These are the different types of probes. On the first picture, this is 4 into 10 millimeter Collins. It is Trichiasis probe. Second one is a 1.5 millimeter curved cataract probe. And third one is the 3 mm glaucoma probe. These are different probes which used in the retina. In the first picture, it is 2.5 mm standard retinal probe, 2.5 mm mid-reach retinal probe, and the 2.5 mm extended retinal probe. These are different types of the instrument we use. Cryo probe for the retinal ball, cryo probe for retina spatula, cryo probe for the retina D-shape, and the cryo probe for the retina bonnet shape. Now, how we prepare the patient? For retinal cryopraxy, either topical anesthesia or the subconjunctival injection of the local anesthesia, which is lignocaine, in the same quadrant as the lesion is treated. For conjunctival neoplasm, lead neoplasm trichiasis, local infiltration with the anesthesia is done. For peripheral cryoablation of the retina or the choroid, and the cyclocryotherapy for the glaucoma peri-bulbal block should be given. Now, what is the technique? Before beginning, make sure that there is adequate gas within the tank and the connection has been made correctly and tightened. Proper cooling of the tip should be checked by depressing the foot switch. After appropriate anesthesia has been instituted, the cryo probe is applied while still warm to the tissue undergoing the treatment. The foot switch is then depressed to allow coolant to flow to the tip. An ice ball should form at the tissue tip at the tissue and at the tip. Once the tissue has started adhering to the tip, the probe should not be moved because of the risk of tearing or breaking of the tissue. The freeze application is limited to the time specific depending on the lesion, and then it is allowed to thaw. What are the different complications? Most of the complications from the ocular cryotherapy are related to the surgeon inexperience and the prolonged contact of the cryo probe or cryospray with the surface tissue, leading to an overfreeze. Depending on the tissue undergoing the cryotherapy, the most common complications are transient uveitis, temporary chemosis, subconjunctival hemorrhage, corneal endothelial damage, paralysis of the extraocular muscle from the cryotherapy over muscle insertion site, sectoral iris atrophy. These effects are rarely have long-term consequences. Cryosurgery, specifically with the liquefied nitrogen, should be performed carefully and only after adequate practical experience.